Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. So today we're going to talk about an approach to the abdominal radiograph. There are very few indications left for the abdominal radiograph. A lot of concern for acute pathology will be evaluated by CT following known pathology, whether it be infectious, inflammatory, neoplastic, or traumatic etiologies will generally be done by CT. Following known bowel obstruction, looking for ileus, or looking at general placement of support devices are the sort of indications you might get for abdominal radiograph. Radiographs are also still used in children, still used in certain pediatric and neonatal populations and indications, but we're kind of mostly talking about the adult here. So as usual, big picture sort of approach, you're going to take a look at the patient history and indication to understand what's going on. And it's going to be important to take a look at the patient anatomy if you do have prior CT or MRI imaging to kind of get that fuller picture before you take a look at just a radiograph. Then you're going to, when looking at the study, we'll see if there's any parts omitted or any other limitations. You'll look at support devices, lines and tubes. It's really important. It's important to take a look at the lower chest, in which can be a common blind spot in terms of new or kind of missed pathology. And then the next step, I like to look at the bowel loops. We're going to look at for distended loops, things and other obvious pathology that we could see on a radiograph. We're going to look for radiographic signs of free air. Do our best effort to look at the solid organs, the fat planes surrounding the solid organs, and abnormal densities, and then finally look at the bones and soft tissues. All right, so let's get started. Okay, so here is a 3 view of the abdomen in a patient. We'll provide an upright view and 2 supine views, one a little higher, one a little lower. And so if we've done our homework and understand what is going on with this patient, let's just start with the upright view. And what I'll typically like to do and make sure that I do is take a look at the lower chest, look at the lung bases, note that there's lung behind the diaphragm, look at the parts of the heart you can see. Figure out if you can see the whole diaphragm here. We may lose a little bit of it there. We're looking for mass lesions or nodules. It can be easy to pass pulmonary nodules, some sort of incidental pathology that we're imaging at the edge of the study here. Okay, so I make sure I look at that so I don't forget. And then the next step typically is I'll look at the bowel loops. And on the upright, both on the upright and on the supine views, you can look for distended loops, but on the upright, right, the view, you're going to look, for air fluid levels. You want to look for stacking, for abnormal dilatation, for displacement of bowel loops. Okay, and we're going to look on both the on basically every view for that. And we're gonna have to figure out for yourself whether these represent just small bowel loops, whether there's includes large bowel loops. You want to figure out if any process, if they're all filled with air, which basically what is involved and to what extent can you see it. And then if you're confused about what loops are what, sometimes you can get a sense from the bowel markings, and you can check on prior imaging as well to see if there's an abnormal distribution in the abdominal cavity. All right, and when looking at those bowel loops, sometimes rarely you can now you can see pneumatosis or abnormal air on the wall. It's going to be fairly infrequent now that we primarily rely on CT imaging for these sorts of acute pathologies. Once you've taken a look at the bowel loops, the next major step that I do, especially if you're provided an upright view, is to look for signs of free air or pneumoperitoneum. These sorts of things would be like loosened liver, air outlining diaphragm, like continuous diaphragm. You can see kind of like outlining this little ligaments, such as the falciparum ligament, or just up near the upper abdomen, outlining the liver, or other solid organs, the upper abdomen. That's generally on the upright view. You can sometimes see outline the gallbladder. On supine views, it's going to be much more difficult, and you're basically not going to be, it's going to be very difficult to find free air unless free intra-abdominal air unless there's a lot of it, but you could sometimes see outlining of the falciform ligament. Decubitus views, or kind of like a cross table, like supine, can be helpful in these sorts of circumstances if you're trying to sort it out on radiograph, and for whatever reason, you don't want to get a CT, but frequently CT will be even, much more sensitive there. So we're going to look for that, on either the upright or lateral. You also look for that wriggler sign, seeing both sides of the bowel wall. Even though we're going to see, have very limited view of the solid organs, you can kind of see here the liver edge. Sometimes you can see an outline of the spleen. You can, see the kidneys. You can see the psoas muscles. You can sometimes see an outline of the bladder and surrounding fat planes. We're going to just make sure that there's not any obvious displacement of bowel loops in one way or the other, obvious displacement of normal fat planes, abnormal calcifications that aren't explained on prior imaging or by the context, and just kind of getting a overall gross sense as to whether there's something you can kind of pick up, even if radiograph is not going to be particularly sensitive. Ultimately, here on both the supine views, you're going to get different. With the different views, you have to be just very careful that you're looking at the edges of the study as your different views are going to capture different parts of the anatomy. And the last thing I like to do is take a look and just make sure I do a survey of the osseous structures, the lower thoracic cage, the spine, including the pedicles, the posterior elements, the vertebral bodies, and make sure that there's no obvious acute or aggressive osseous lesion, destruction of the normal cortical appearance of the cortex, and then again and then kind of similarly looking around the osseous pelvis and the incidentally image upper or the upper aspects of the lower extremities, just to make sure that those are okay, and then looking around the edges of the study of the subcutaneous tissues, just as a quick survey to make sure nothing else is going on. As a quick summary, the approach to the abdominal radiograph can be fairly straightforward. We're looking at patient context, understanding what's going on, using prior cross-sectional imaging if you have it to understand the underlying anatomy, and then as you go through, seeing if there's anything missing from the study, seeing if there's any limitations, looking at support devices, making sure you look at the lower chest, looking at those bowel loops for distension typically, for whether or not they're filled with air, if there's air fluid levels, then looking for signs of free air, assessing as best you can the fat planes and usual solid organs, and then finally looking at the bones and soft tissues.